Hello, everyone. I'm Kyungmi Choi. I use she, they pronouns. I'm a professor in the Department of Counselor Education at San Jose State University. With the Ohana Center of Excellence, I serve as a program specialist and regional community facilitator. Many of you already know what we are doing. The Ohana Center of Excellence serves diverse group of populations of Asian Americans, Native Hawaiians, and Pacific Islanders. Our mission is to be a source for empowerment, education, and support for individuals seeking behavior healthcare, including mental health and substance use resources. We center holistic and cultural approaches to serving the needs of the AANHPI communities. We also provide training and technical assistance for those working in substance use, behavior, and mental health to better serve the needs of the AANHPI communities through culturally responsive care. Today, we have a very special speaker, Dr. Pata Suemoto, the director of the National Asian American Pacific Islander Empowerment Network. She's also the associate director of equity for MCSP and the co-chair of the Greater Boston Regional Suicide Prevention Coalition. Dr. Suemoto is founder and co-chair of MCSP Alliance for Equity and one of the authors of Widening the Lens, Exploring the Role of Social Justice in Suicide Prevention, a racial equity toolkit. Dr. Pata Suemoto is feminist scholar, writer, educator, curriculum developer, equity trainer, mental health activist. We are so honored to have you with us today. I will go ahead and hand it over to Dr. Pata Suemoto.
Thank you, Kyungmi. Let me share my screen now. Okay. Okay, so this webinar, we need to talk about it, stigma, shame, and the importance of conversations about mental health and suicide prevention in AANHPI families and communities. I'm sorry, there's a typo in the title. I apologize. Anyway, so I want to thank Shani Butts and Natalie Asun for their help and insights in developing this webinar. And I want to start by introducing NAPIMA, which is one of the organizations I work for, in addition to the Mass Coalition for Suicide Prevention, which was mentioned earlier. The mission of the National Asian American Pacific Islander Mental Health Association, or NAPIMA, is to promote and redefine mental health and well-being of the Asian American, Native Hawaiian, and Pacific Islander individuals and communities through training programs, policy and advocacy, and centering those with lived experience. In this webinar, I will be using my lived experience. I am a person with lived experience, and to talk about some of these issues and as a resource for my talking points. Okay, let's see. So just an introduction to me and my lived experience. That picture is of me and my parents, the baby picture. And you know, no one ever is born and their parents say, oh, gee, this person's going to have mental health concerns. But a lot of us do. You know, as an Asian American who is a suicide attempt survivor with lived experience with complex PTSD and chronic depression, I have never experienced what it's like to have my cultural background acknowledged, never mind addressed in the mental health field. That is until my current therapist, who asked me a few years ago how being Japanese American affected my experience. Before that, and I had been in the system for a long time, no one had ever asked. I grew up in the 70s in a primarily white community where I was actually aware that I was not, or I was acutely aware that I was not white. My family also has an oppressive legacy, as my Japanese American father was incarcerated in an American concentration camp during World War II. I grew up with a visceral understanding of racial oppression. I was also a baby feminist in the 70s, where I learned to question gender inequities and oppression in general. In much of my professional life as an educator, I have developed and enacted anti-racist curricula. I grew up in a family who has experienced intergenerational mental illness. My mother had bipolar disorder with psychotic features. My aunt on my father's side died by suicide. My father and uncle dealt with major depression. My family history is riddled with severe mental illness. Personally, I've suffered with chronic depression and complex PTSD since I was 12 and in junior high school. At 16, I tried to end my life, and I managed with depression and PTSD without intensive treatment until my 30s. In my mid-30s, I had a severe episode which resulted in my dealing with chronic PTSD and major depression for the past 25 years. People who haven't experienced depression, complex PTSD, and suicidal ideation often have a difficult time understanding it. When you say you have major depression, people don't think that people who don't have that diagnosis think they understand what you are experiencing. Yet I submit that the experience of major depression and PTSD is not really understood by most folks who don't suffer with these conditions or work with people who have these conditions. It's important in my life to speak out for a number of reasons, many of which I will talk about in this webinar. However, personally, it's been healing for me to share my recovery story and engage with others who are struggling to share hope and healing strategies. So, talking about mental health and why we need to talk about it. AANHPI folks tend not to talk about mental health concerns in our families and communities in ways that promote recovery. We do talk about it sometimes. We say, "Oh, that my crazy aunt," or something like that. But we don't often talk about it in ways that really address the recovery process. When I came to my dad when I was a young adult and told him I was suicidal, he turned away. His whole body turned away. And I realized at this point he just couldn't deal with it. But at the time, it was really damaging for me because I was sharing something that he couldn't address. So not talking about the elephant in the room, if you will, is a problem because AA and HPI folks have mental health concerns and sometimes at higher rates than other ethnic groups. This is just a slide that shows the prevalence of mental health, and mental illness and substance use disorders in AA and HPI adults 18 plus. And this is just to say that it's a problem. 1 in 7 had serious mental illness. And that's a lot of people. And so it's not like sometimes people think that Asian Americans, Native Hawaiians, and Pacific Islanders don't have mental health problems. It's not in our community, but I beg to differ and say it is. In terms of suicide, the rates for Asian American Pacific Islanders of all ages was approximately half of the overall U.S. rate. But if you look down at Native Hawaiians and Pacific Islanders, the rate is much higher, also higher for multiracial people. And although it's a 12th leading cause of death for Asian American Pacific Islanders adults, it was the first leading cause of death for youth, ages 15 to 24. So I think that's really notable. So one of the things is like what gets in the way of talking about mental health recovery in our communities? And I would say it's not simple. There are many factors. And I'm going to go through a number of things that I have thought about and discovered as factors in what gets in the way, and hopefully be able to talk about some of the things we can do about that. First is a cultural framing of mental health. There is a mismatch between the services and interventions and the cultural norms and how mental health is framed in different cultures. There's a mismatch between the dominant culture and the AA and HPI cultures. We know some languages don't even have words for concepts in Western psychology. And it's important to understand the words in language for mental health concerns, because they may not be the ones we're using in the Western framework. And AANHPI cultures don't separate body, mind, and spirit the way that Western medicine and psychology does. And so the whole cultural framing of mental health is not the same for dominant culture versus AANHPI cultures. In addition, the stigma in AANHPI cultures is often more extreme than in the white American culture, in the Western culture, around mental health. And, you know, I mean, some of that has to do with that framing issue where, you know, we frame mental health a certain way and then therefore can talk about it in certain ways. There tends to be some silence and denial about mental health issues. In my family, there was a lot of that. And we are told that we'll lose face if we admit to depression or other mental illness, that we'll shame ourselves and our families and even our communities. The message is that mental illness and suicidal ideation is a result of personal failure and not an illness or a result of environmental stressors such as poverty or racism. And I think a lot of times that mismatch and that inability to talk about it comes from not knowing what to say, right? So some of it has to do with, you know, if you don't understand the illnesses, then you often don't know what to say. And other times, I think people don't talk about it. People who are suffering don't talk about it because they don't want to be a burden. They don't want to worry others. And from my experience, actually more worry happens when I feel like there's something wrong, but no one is talking about it. So I think that that's really important to understand that saying it is not going to cause an issue. And it also is important to know that, you know, people can feel when there's something wrong. And if you don't talk about it, that uncertainty can be even more problematic. Another contributing factor to mental health concerns that we don't talk about is social determinants of health. The social determinants of health are the non-medical factors that influence health outcomes. They are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So there's a following list of things that can contribute to a person's health and influence health equity in positive and negative ways. So income and social protection. If you don't have it, you have the trees, that barren tree versus the fully bloomed tree. Education, again, you know, if you don't have education and, you know, you have a poor educational system, your outcomes are going to be less positive. Unemployment and job insecurity, working life conditions, food insecurity, housing, early childhood development, social inclusion and non-discrimination, structural conflict, and access to affordable healthcare services and of decent quality. So research has shown that social determinants of health can be more important than healthcare or lifestyle choices in influencing health. For example, numerous studies show that social determinants of health account for between 30 and 55% of health outcomes. So these things matter a lot. And I think, you know, when we think about how we deal with mental health concerns and, you know, whether our communities are getting the things they need, part of it has to do with social determinants of health, not the individuals or the communities themselves per se. Another contributing factor to the way mental health is perceived both in our communities and outside of our communities is the myth of the model minority. So the model minority myth that Asian Americans in particular, and in talking to Native Hawaiians and Pacific Islanders, they were talking about it depends on how they're seen or viewed in terms of whether they get the brunt of the model minority myth or not. But The myth says that unlike other minorities, Asian Americans are succeeding according to the benchmarks of the dominant culture, and therefore do not need special services and are held up as a model for other people of color. And this is the dangerous narrative that we did not create. The dominant white supremacy culture dubbed us as a model minority in order to pit us against other non-Asian people of color. And we are used as a pawn to divide and conquer. Although the model minority myth does provide us with certain unfair advantages, they are only granted to us if we're good Asians and accept the white supremacy culture. And these are advantages we did not earn, and they have their limitations. For instance, although on average we have higher levels of education than other people of color, we are also least likely to get promoted to managerial positions. And, the model minority morphs into the yellow peril when it is advantageous to the dominant narrative, like we've seen with the racism as a result of COVID-19. And the result of our own complicity with the model minorities myth is internalized racism, where we work to be white, as white as we can, and ignore our cultures and specific cultural needs, as well as the system of oppression that works against all of us, all people of color. One can argue that using the umbrella term Asian American, and even AANHPI, rather than disaggregating the data of different groups, that provides an accurate picture of success that's being promoted. We can also argue that being labeled the model minority does not ameliorate the racism in this country, and in fact, by pitting us against other minorities, quote unquote, it makes it worse. The model minority myth distracts us from the real issue of increased suicidality and depressive symptoms in Asian Americans, Native Hawaiians, and Pacific Islanders, especially in our youth and elders. It creates a myth of unnecessary pressure for those of us who do struggle with mental illness, or those who don't do as well and aren't as quote unquote successful. The burden of mental illness is exacerbated by racism and stereotypes and the model minority. Furthermore, culture and its impacts are often not addressed in mainstream psychology, which remains primarily a white field. And this is played out in my experience also in a number of ways. In addition to the model minority myth, AA help-seeking patterns are that we don't seek as much help, right? And the reason this study is of Asian Americans, not necessarily Native Hawaiians or Pacific Islanders. So I wanted to make it clear that I did not find a related study for NHPI. And that also speaks to the fact that we don't have research. Asian Americans are understudied. Native Hawaiian and Pacific Islanders, I would argue, are even less studied. So that is a problem in the field as a whole. But the National Latino and Asian American Study reported that while 18% of the general U.S. population sought mental health services and resources, only 8.6% of Asian Americans did so. A related study found that while U.S. citizens take advantage of mental health services at 3 times the rate of their Asian American counterparts. And generally, the result of this often is that people who go into services, Asian Americans who go into services, tend to have a higher level of distress, and their symptoms are more severe than people who enter treatment earlier. So what are some barriers? And it's not just, Asian Americans don't go because there aren't Asian American practitioners, which is true. At the same time, there's a whole bunch of things that play into why we may be less likely to seek help. And this plays out a number of different levels. On the individual level, there's stigma, losing face, fear of appearing weak, relationships with family. I've talked to many Asian American, in particular, people who say that, you know, when they told their parent or whoever that they were thinking about therapy, they were immediately shut down. So on a cultural level, AA and HPI cultural norms of the insider group and outsider group, there might be a mistrust because of that of Western behavioral medicine, a mistrust of talking to a stranger, you know, as well as, you know, the mismatch of cultural norms that we talked about earlier. Institutionally, there's a lack of insurance, lack of interpreters or in-language providers, lack of culturally responsive or culturally humble providers or interventions. And systemically, there's a lack of pipelines for providers and lack of research on AANHPIs, which I mentioned before. So altogether, it's on all the different levels that what might create barriers to seeking help, and also finding help that is culturally responsive. So just briefly, I mean, Western treatment modalities, you know, therapy is one treatment modality, and it's an important option, I believe, for people. It has helped me immensely. And one of the things I want to say about therapy from my own personal experience is that if you are seeking therapy, realize there are many kinds of therapy and that there are many kinds of modalities, and that you should educate yourself before you jump in. But at the same time, there's also a lack of relevant care for AA and HPIs. Finding out if a person is culturally aware and responsive and culturally humble, even if they're not part of your group, is also important. Medication is also an option for people. There's a bunch of myths about medications. For instance, there's a myth that if you take medication, you'll be on it forever, which is not always the case. There's a myth that it changes your personality, and that's also a myth. My experience is it raises the bar, so I wasn't so distressed, so I could do the healing I needed to do. Another myth is that it cures your mental health condition, and that has not been my experience at all. I've had treatment-resistant depression, which means I've taken a lot of medication with no effect. About a number of years ago, a doctor found the right combination for me, but it took about 10 years to find that combination. So, but it has been really important in my recovery to be able to have the support of medication. I wanted to speak briefly about suicide prevention because it's so important. At least, you know, my work straddles both suicide prevention and Asian American, Native Hawaiian, and Pacific Islander mental health concerns. So I do sort of both pieces, and it is Suicide Prevention Month. So it is a time to really think about how we might react if someone in our lives or ourselves felt suicidal. First, it's the thing that's important is not, I mean, every threat of suicide should be taken very seriously, even if it's a throwaway. Oh, I don't want to live anymore. I mean, you know, that comment could mean something more than a throwaway. So I think it's very important. The other thing is that, you know, it's not a time to be quiet or minimize the situation. You know, asking a person if a person is suicidal will not put the idea in their head. And in fact, a lot of the time, in my experience, when someone asks me, it's a relief because it's like someone notices your distress. It's, you know, it's a time to listen, offer support and resources, not a time to give advice. And if you want to learn more about how to talk to someone who's having a mental health crisis or a mental health issue, NAPIMA does mental health first aid trainings for our communities, and we are going to be offering them in the near future to anyone who's interested. So I'll provide more information about that in a minute. The other thing is to get assistance. 988 which is the suicide prevention lifeline, suicide and crisis lifeline, 988, is a new service. It's a year old, just a few weeks ago, it became a year old. And it's funded by SAMHSA, or the Substance Abuse and Mental Health Services Administration. And it's a call, text, and message line, and it provides free and confidential emotional support to people in suicidal crisis or emotional distress 24 hours a day, 7 days a week across the United States. And that's really important. If you are a person who is in distress and needs help, or you're a person who is helping someone, 988 could help you out. 988 offers trained crisis counselors who can help people experience mental health related distress, and that could be thoughts of suicide or mental health or substance use crisis or emotional distress. You don't have to be on the verge of suicide to call 988. 988 provides crisis call, text, and chat services in English and Spanish, and uses a language line solutions to provide caller translation in more than 240 additional languages. And currently 988 calls are routed to the closest 988 center of the area code of the phone that's being used. Now, a lot of times, as we know, I mean, I have a Massachusetts, I live in Massachusetts, I have Massachusetts area code, but I might be traveling in California and I might call, from California. So if that's the case and you want local services, you need to tell them where you are located, what state you're in, or what area code it is. And this is a alternative to what has been recommended before, which is call 911, where you're more likely to get law enforcement that may or may not understand crisis services. So this, I think, is an important resource for people to know about. And in some situations, when there's a serious risk to life and a person poses an immediate danger to themselves or others, a crisis counselor may refer a 988 call to 911. But you just need to know this happens in fewer than 1% of the calls of 988 Lifeline. So if you are concerned about, getting law enforcement involved, 988 is a much better choice to call if you are in a mental health crisis. I think a framework that can help us understand how to work with cultures that aren't our own, how to engage, is this difference between cultural competence versus cultural humility. And everyone on both a personal and professional levels brings different lenses and perspectives to the work we do, whatever that work is, if it's mental health work or not, relevant to our own identities, including our own cultural lenses. When we talk about being cultures that aren't our own, the question is, how can we become educated, responsive, and effective in collaborating and building partnerships that lead to effective work and relationships? And we believe that the concept of cultural humility, as opposed to the idea of cultural competence, allows us to be better partners, have more effective be more effective collaborators, and allow our approach to respect the expertise and authority of the community in which we are working. So cultural humility was first forwarded by Melody Travelon and Jan Murray Garcia. They said, this is a quote from their article, the traditional notion of competence in clinical training as a detached mastery of a theoretically finite body of knowledge may not be appropriate for this area of physician education. Cultural humility is proposed as a more suitable goal in multicultural physician education. Cultural humility incorporates a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to develop mutual beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and defined populations. So cultural humility started in physician education, but is definitely, I believe, translatable to all of behavioral health. So cultural competence assumes we can know or gain expertise in a culture other than our own, and that doing so we can eventually come to a full understanding of the needs of a particular group, as well as how to address those needs without asking for input of any members of the group. You can take a training, a cultural competence training, and get certified in cultural competence. But in my mind, it feels ludicrous that I could be culturally competent in any culture other than my own, even my own culture. I mean, not everyone who's mixed heritage Japanese American growing up in the East Coast has the same experience. So cultural humility listens, okay? It assumes we must listen and rely on the expertise of members of the cultural group with which we are working, not only to better understand the needs of the group, but also to better frame our work in the relationship to their cultural norms and broader context. So, when we think about cultural humility, we're really looking at who's in front of us, right? Cultural humility values different frameworks. I mean, cultural competence assumes we can adapt existing mental health and suicide prevention models and the educational approaches which exist within the dominant framework by using language and sometimes norms of the culture or group with which we are working without questioning whether these materials would work in a different cultural framework. I think this is really important for us in the AANHPI community, because a lot of times it's like, oh, we'll just change the names, or we'll just translate it into another language, as opposed to really thinking about, well, culturally speaking, are these approaches going to work? Cultural humility understands that adaptations to current approaches are only part of the necessary framing, and new models and approaches must be created. So, the idea that we need to look within a culture, within a group, to figure out what is working and what needs to be changed, as opposed to taking models from outside the dominant culture and just basically pushing them into a different culture. So, and I think this is important for all of the work we do. I think that cultural competence assumes a dominant cultural perspective is normative rather than a cultural lens, just like any other lens. Cultural humility assumes there's no normative or monolithic culture, and that culture, all our cultures, have a lens. Cultural humility does not place the values of one culture, particularly the dominant culture, above other cultural norms and values. So, a lot of times the dominant culture is considered to be the norm, and that is a cultural humility, is saying it's not the norm, it's just a cultural lens, it's a way of looking at the world. It is one that has been used to assimilate people and to colonize people. And I think it's time that we really look at our own cultural lenses and really reclaim them. So how culturally related to AANHPI mental health? Well, first, there are at least over 50 different cultures and ethnicities and hundreds of languages. So if we don't have cultural humility, then we're not actually understanding who's in front of us or who we're working with. There are also primarily white clinicians in the field, and that population needs to be thinking about how to do cross-cultural work if they're working with people of different cultures, and how to be culturally humble. And this is not to say that cultural humility means that there's no homework involved. If you're working primarily in a particular group that's not your own, you need to find the cultural brokers. You need to talk to people. You need to listen to the experts in front of you. But you also can't just say, oh, I'm just going to ask questions and just be culturally humble. No, it means like finding out information about the culture and finding out norms of the culture, preferably from people who know that culture, people within the community. And then, and really listen to those perspectives and that worldview. And one of the things that if you're a clinician and you're working cross-culturally, I invite you to question those behaviors and beliefs that seem unusual to you and ask what's going on here rather than pathologizing the situation or saying that somehow it is not quite it's not right, or it's not like, what you expect. It might not be what you expect, but then whose cultural lens are you using? So I have this passion about talking to children about mental health. Growing up in a family where my mother's mental health, my mother's bipolar disorder was often talked about in hushed tones as a secret. And and as a child growing up, I thought it had something to do with me. I think all children think, developmentally think that they are at fault somehow when things are going wrong. So it is important to talk to children about what's going on if there's mental health concerns within the family, because they assume it's their fault, and that is not accurate. In addition, being able to talk about mental health and acknowledging feelings and talking about how to manage feelings is a life skill that young people need. So one of the things that I did, as opposed to try to keep secrets as my daughter was growing up, that's a picture of my daughter. She's young, and that's me young, very young, is to say to her, I said, Mommy has an illness that makes her sad, and it's not your fault. It's not your fault. Because I needed to counter the her tendency to make it her fault, to make it that she did something wrong. The other thing that happened as a result of these conversations about mental health growing up, we would talk about her feelings, we'd talk about my feelings, but now my daughter will refer her friends to me, or will talk to me about a friend who's in distress and how she could help them. So I feel like this has created a conduit for conversation about mental health, about feelings, about this part of our life that is so important. And mental health is more than mental illness, right? It really is body, mind, and spirit. We all have mental health. It's important to promote whole health and wellness. And I think this body, mind, spirit focus is more culturally appropriate paradigm for Asian Americans, Native Hawaiians, and Pacific Islanders. NAPIMA has a program that I'll mention a little bit later more called Achieving Whole Health, Body, Mind, Spirit. And it is a wellness program where people learn about sort of framing the body, the mind, the spirit, and then set up health goals for themselves and their community. Everyone has mental health. Everyone has mental health. And what can we do? We can acknowledge that everyone has mental health, and it's not the same as mental illness or even mental distress, right? I mean, everyone can have ups and downs of one's moods and life, and it is nothing. It is quote unquote normal, right? It is what we are as humans. But it's also important to acknowledge that mental illness is just that. It's an illness, and it can be treated. Okay. I mean, I think I am living proof that one can go from being very, very depressed to being able to have leadership roles and have use my lived experience to inform others. We need to identify individuals and communities' resilience. so much of our experience in this country as AANHPI folk, we've been confronted with racism, we've been confronted with colonization, immigrant stories that are very difficult. So I think we need to realize that we have a lot of resilience. One of the things that we can do is to share information, particularly with people, leaders in our communities, cultural brokers, for mental health and suicide prevention. We don't talk about these things as much as I think we need to. And I also think that, the one way to get this out is to go to our faith leaders, to go to our community places where we meet in community, to talk about these issues. And we need to have cultural humility in our treatment and approach to help and help seeking. It's not a one-size-fits-all situation, because there's different cultural aspects, different cultural norms. There's age differences, and there's intergenerational conflicts, which we also need to address. I don't know how many times I've heard young people say, my parents just wouldn't understand it. And, so as a community, I believe we need to address these intergenerational conflicts and create bridges. And we need to challenge ourselves, to talk about these issues, mental health, mental illness, in order to prevent suffering and suicide. And I think, it's not just about, people who are suicidal. It's about all of us. And I think we need to really realize that. Also, we are resilient, and we have Indigenous ways of healing. It's not, there's a Western paradigm, but there's also other ways of healing, such as acupuncture and herbs, yoga, hula, being in harmony with the ocean, healing circles. All of these are ways of healing through the arts. NAPIMA has a whole program for healing through the arts. Acupuncture has been pivotal in my healing. I hit a wall a number of years ago where I felt like all the traditional Western approaches weren't doing anything. And so I saw a brilliant acupuncturist who helped me stay alive in some of my deepest crises. So I think we have to realize that it's not like, okay, we only have this road, this path. There are many paths to healing, and that we need to find the right one for us. And I think it's really important that we think about the ways that we can use our Indigenous ways of healing, as well as Western ways of healing and other forms of treatment and intervention to create the best possible healing journey for ourselves. So just a final reflection is, and I have a couple other slides about NAPIMA, but I really think that if we're going to improve the mental health of AANHPI individuals and communities, we've got to start talking about it. And we have to start making it clear that our communities have issues and need resources. We need to disaggregate the data. We need to look at where in our communities is there more distress, and where do resources need to go. We need to realize that mental health is part of overall health, and we all have mental health, and that we need to take care of our mental health as we do our physical health. Self-care has, come to mean like spas and doing your nails, but I really feel like it's much, much more than that. I have a friend who talks about soul care, and the idea that we need to replenish ourselves. We cannot go and be depleted and and help somebody else. We have to take care of ourselves too. So I really feel like one of the things that we can do is to start sharing more and really, kind of figuring out, well, where are the resources we need? And one way to think about this is to get involved with NAPIMA. I am the director of NAPAN, which is the National Asian American Pacific Islander Empowerment Network, which brings together Asian Americans, Native Hawaiians, and Pacific Islanders who have lived experience with mental health issues, either as individuals or as impacted family or friends. We work to support each other in a world that marginalizes AANHPIs and those of us with mental health challenges. We share our unique experiences, knowledge, and perspectives to inform mental health awareness, practices, and policy. We aim to tear down stigma and stereotypes and work toward liberation within our communities and beyond. So NAPAN is an organization that we are working in two folds, and in our inner fold, which is about supporting each other, and externally to share out our knowledge. We are having a network meeting on October 15th. If you are interested, please go to the NAPIMA website and go to NAPAN and sign up. There'll also be stuff on social media, etc. And at that meeting, we'll be talking about things like the special interest groups we're starting. We're starting one on parenting, one on creatives and healing through the arts, and one on professionals, particularly professionals in the mental health field, professionals who have lived experience themselves. I mentioned the Achieving Whole Health program, Body, Mind, Spirit. We will be running Achieving Whole Health programs in the next couple months. If you're interested in this program, please look on the NAPIMA website, or you can also email me. I'll put my email in I will put my email in the chat when I have a chance. And people can email me if you're interested in learning about the Achieving Whole Health curriculum, either for your organization or individually. And as I mentioned, we are doing mental health first aid trainings. They will cost $20, which is a deal. And we're opening them to the communities both in November and December. And so if you're interested in that, again, you can go to the NAPIMA website or just email me. Mental health first aid, just FYI, is an 8-hour training that teaches someone how to deal with someone's developing mental health problems or experiencing a crisis. So it's how to talk about it. And so now I'm open for questions if anyone has any. Let's see.
Thank you so much, Pata. Yes, there are some questions here. So we get a copy of the slides and access to the recording. I can answer this. Yes, it will be available via our website, and please check out website. We have so many previous webinars, future webinars, and Pata's webinar slides handout, and then recording will be available for all of you. The next question you mentioned about the 3-digit 988.
Mm-hmm.
Are you aware other language options, especially Hawaiian languages?
Yeah, they have a language translation. I do not know, actually. I should know this, whether they have native Hawaiian languages. I think it's I am actually on a couple of 988 committees, and one of the issues was about language access. It's a huge issue, and even when you have an interpreter, that's another level of another area where one could create miscommunication, right? So, I mean, it would be much better to have in-language providers, but we don't have in-language providers for all of them. We also don't have, not all call centers have interpreter training too. So I think this is an area which we are lacking in. And, I think, I mean, I haven't called 988. My daughter called 988 to try to get services when it first came out, and it didn't work so well. I hear it's better now. So that's good. But in terms of language access, I think we are still lacking. And I actually, but I'm going to follow up and find out what languages exactly, what Asian, Native Hawaiian, and Pacific Islander languages are, service that they have services in. I don't know. If I were to guess, I would say they don't have them, but that's just me guessing.
Thank you. The next question is, are there any art programs?
Yeah.
You mentioned, yeah, can you share a little bit about that?
We have Asians in Focus, which is a NAPIMA program, and the Asians in Focus, we had a program called Heart's Hope, which we solicited art from the community for suicide prevention. We had a family whose son had died by suicide, and they provided us with some funding, and so we solicited messages of resilience. And so you can go on our website. It'll link you to the Asians in Focus website, and you can actually look at some of the artwork and things. We also incorporate art into a lot of our programming. We have a youth program called Friends Do Make a Difference. And in that program, there's a lot of artistic expression as part of healing and, expressing feelings and that kind of thing. So look at Asians in Focus and the work we've done there. There was also a photo voice project from Asians in Focus, which is basically a research project using the information from the photographs as well as the narratives that were provided.
Next, some question about the trainings you share. Are those trainings and workshops are only for professionals or for everyone who are interested in?
Actually, the trainings that I shared are for everyone. Professionals are more than welcome, but mental health first aid, for instance, is a community. It's for community members. It's for anyone who's interested in talking about mental health, or people like librarians, or teachers, or whatever. I mean, so all those kinds of people. And the Achieving Whole Health too. That is a training that is meant to be a kind of peer-to-peer training. It's not, you don't have to be a professional to train, and you certainly don't have to be a professional to participate. It's really about improving our health as individuals and communities together.
Yeah, and this is the last question.
Sure.
So, do you have any recommendations or resources for talking about mental health issues with the AANHPI family members who do not believe in mental illness?
Yeah, it's a hard one. That's a hard one. I do think finding first finding bridges. I'll just call them bridges. So if you, like, for instance, if you're trying to talk to if you're trying to talk to, like, your mother and they're not having it, you might find maybe your aunt is more willing to talk about it. So finding these bridges, I think, are really important. At the same time, I think hold on, I'm just putting my email in here. My email is kind of weird. I just typed it in the answered questions for anyone who wants it. I think also finding people with lived experience to share a little bit. If like, your parents' friend, had an issue, see if they could talk to them about that. I think, in my experience, it hasn't really, well, I can stop sharing. It hasn't really worked to, like, you know, provide the research or whatever, you know. At the same time, depending on the person, you can also do that. You could provide, you know, statistics about, for instance, suicide, right? I mean, providing some of the stats on suicide, particularly about young people, I think can make people say, really? You know, and maybe pay attention to it better. But it is a hard thing. As part of the Breaking Silences project, which was mentioned in my bio, we have a play. It's actually a play, the Breaking Silences, and it's a 10-minute play. And in the play, there's a scene, a vignette with a mother talking to a daughter who is trying to express that she wants to go into therapy and wants to get some help. And so, you know, the daughter says, but mom, I've been feeling suicidal. And the mom says, work harder. And you always know you're in an Asian American in particular population when people laugh at that, because they're so familiar with that. Just work harder. Just work harder. Don't pay attention to the mental health concerns. And, you know, the point of that is to, you know, in some ways is to show that, you know, that is not particularly helpful to say, you know, just work harder, right? Because that person doesn't feel heard, doesn't feel like they have a moment to you know, doesn't feel like their concerns are being addressed. And I think that, you know, I would say don't give up. When you're talking to your family, you know, they may reject it, but just let it be, you know, like, and then come back to it. Maybe with a different thing, maybe through a novel, maybe through a book, maybe through a friend, you know, just continue the process of trying to educate. Because I think I think a lot of what's going on in our communities is that people really don't know. And, you know, I think this educational process is really important. So thank you all very much.
Thank you so much, Pata. You share so much about your personal experience, your wisdom, research, and resources, and some examples that it's really, really helpful for all of us. I see positive comments here. Thank you so much. And again, this webinar will be available for everyone. You want to watch it again and revisit those resources. In the meantime, I would like to share my slide one more time. So please join us, our website. Again, this webinar will be available for all of us. Our website has so much information that will support your work. And don't forget that we have social media, many different channels. You can connect with us, learn about our upcoming webinars and resources. And also we need you. Please join us and join a regional steering committee or national committee. We want to hear your voice, and your input is so valuable. So let us know and just send us your short application and we will contact you shortly. And this is our email. Please join us. And then most importantly, we really appreciate your feedback. So take our post-event survey and let us know how you think, what you learn, what would you like to hear from us, learn from us in the future. So really, really appreciate your feedback. And this actually concludes our webinar. Thank you so much for everyone joining us and sharing your questions. And thank you so much for all your work. Bye, everyone.